Okay, fantastic. It seems like we have people coming on in, which is brilliant. So we'll just give it maybe sort of 10, 15 seconds so we can get the vast majority through the virtual doors, I guess, if you want to say, into the room. But it's fantastic that everybody is joining us today. Okay, brilliant. We see some people here. So welcome everybody. Thank you so much for joining us. I'm Nathan from the European Pain Federation EFIC, and welcome to today's webinar exploring how stress and social identity can impact coping strategies related to pain management. We'll also touch on the role of mindfulness-based stress reduction in improving psychological health in general as well. So I guess the aim of the webinar is to provide insights into the various approaches for managing pain more effectively. And of course, to do this, we have some fantastic speakers with us today. Isabel and Elena, you might be able to see those on your screen there. Thank you so much for joining us. We'll come to you in just a moment, but we will hear from you very, very shortly. We have two very interesting presentations, and then we'll have some time to discuss your amazing work and thoughts and insights. So just before we start, like all of the live webinars that we do here with EFIC, there's a Q&A function at the bottom of your screen. You might be able to see that. So please use this to ask any questions that you have. We'll do our best to get through all of the questions. We'll do that at the end after both of the presentations have been given. So please pop them into the Q&A function as soon as you have those questions in your mind. You can also do this anonymously as well, if you prefer, which I tend to do on many other webinars as well. So you can do it anonymously through that as well. So it's likely we'll go, as I mentioned, we'll go through all of those at the end once the presentations have been completed. There's also a chat function. So if you have something that's not quite a question, but maybe a comment, you can use that for sort of general comments as well. And a kind of final reminder that this is a recorded webinar, so you can access these discussions at a later time if you wish to do so via the EFIC Academy and social media accounts, and kind of where we put all of the resources to be shared after the live kind of slot. So that's enough for me, I think. Let's move on. Thank you so much for joining us. Maybe we can hand it over to Isabel. Good morning, good afternoon. Thank you so much for joining us. Do you want to begin to share your slides and give us a bit of an introduction to yourself and your work? Thank you so much for joining.
Sure, I will share my slides. Can you see them now?
We can indeed. Thank you.
Okay, perfect. Oh, and I already started accidentally. So hello and welcome, and thank you so much for having me. I'm very excited to present our work on the stress mindset and social identification in chronic pain patients and their relationship to coping, well-being, and depression. Yeah, so we published this article, so I will be referring to one article that we published in a Journal of Clinical Psychology and Medical Settings, and it is an open access article, so please feel free to access it if there is any further interest or questions that could not be answered today. So yeah, but I will take you kind of through the article, and I will start by defining what is meant with stress mindset and social identification, which coping variables specifically were we paying attention to, and let's just dive right in. So the stress mindset is a concept which refers to how an individual perceives stress in general. So whether somebody holds the opinion that stress enhances variables like performance, growth, productivity, learning, health, or well-being, which would be referred to as the stress is enhancing mindset, or whether an individual is of the belief that stress impedes those variables, which is something quite a few people might identify with. So this would be referred to as the stress is debilitating mindset. So it is just about what kind of opinion do you have about the effects of stress, which of course is influenced by what we learn, how maybe our caregivers cope with stress or how they view stress. One might ask why the stress mindset is an important variable and why it might play a role in chronic pain therapy or approaches to handling chronic pain. So having a stresses-enhancing mindset has been shown to have very nice effects on better health, greater well-being, higher life satisfaction, and even better job performance. And this goes through various aspects, like on a psychological side, having a stresses-enhancing mindset, so being of the opinion that stress is something that you could benefit from, leads to lower perceived stress intensity, more positive subjective perception and evaluation of stress. It is also associated with a more positive mood, increased attentional bias towards positive stimuli, and also a higher cognitive flexibility. On a physiological level, having a stresses-enhancing mindset does lead to more adaptive, moderate cortisol levels. And on a behavioral level, it does lead to a stronger desire for feedback and also to more adaptive coping, which is something we will get more closely into later. Social identity refers to having a relationship to a group and the positive emotional evaluation of this relationship. So basically just being part of an in-group, which you can see here on the right, and thinking that it's a good thing that you're part of this group, and also differentiating yourself as part of this group you identify with from an out-group you maybe don't identify with or identify with less. Why is social identity important for chronic pain, one might ask? Chronic pain patients have been found to have lower levels of social functioning, to have fewer social skills, and they also withdraw frequently from social interactions. And interestingly, you can also see that the same brain region is active when somebody feels lonely, like when they feel pain. So there's also some apparently some similar brain areas and activities involved in those two concepts. I think coping as a concept is clear to most of us being here present today, but coping is a very, very broad concept, and there are different coping behaviors one might look at. And so we focused on some specific coping behaviors in order to make it easier to research the effects of stress mindset and social identification on coping. And I will define the 4 coping strategies that we looked at in our study. So we investigated positive reframing as a coping strategy, which is basically looking at a situation from a more positive perspective or finding something good in what happened. We, for example, looked at this because this is also an approach used in psychotherapy quite often. And then we looked at active coping, which means focusing on and trying or taking action to change something about the stressful situation you're in. We also looked at rather social support coping strategies like instrumental support, which means asking others for help and advice, or emotional support, which means receiving encouraging support or sympathy from others. We had quite a few hypotheses. I also have a slide prepared on like the interaction of those hypotheses, so it will get a little more clear, but I'll just walk you through those. So first of all, we hypothesized that chronic pain patients report lower general well-being and more depression than people without chronic pain, just because they do experience a general higher strain due to the pain disorder. And then in hypothesis 2, we assumed that chronic pain patients report a lower stresses-enhancing mindset compared to people without chronic pain, because the pain can be seen as a chronic stressor, which also might influence the general view they have about stress. So stress being rather something negative, because they experience it as something adverse. So then in hypothesis 3, we assumed that having a stresses-enhancing mindset, according to previous research, is associated with the more frequent use of positive reframing and active coping, as previous research showed that having a stress-enhancing mindset can have very nice effects on a psychological level. Then we assumed in hypothesis 4 that a more frequent use of positive reframing and active coping is related to higher general well-being and less depression. And hypothesis 5 kind of takes all of that together in assuming a mediation, so that the relationship of chronic pain with general well-being and depression is mediated by an individual's stress mindset and their use of positive reframing and active coping. And then hypothesis 6 to 9 is basically kind of the same assumption of a mediation just for social identification. So we assume that chronic pain patients do report a lower level of social identification compared to people without chronic pain. Because of these results, those results I showed you earlier, that they often withdraw from social relationships, have fewer social skills, that they also might have lower social identification. Whereas on the other hand, hypothesis 7, a higher level of social identification might be associated with a more frequent use of instrumental and emotional support coping behaviors, which on the other hand, hypothesis 8, could be related to higher general well-being and less depression, and hypothesis 9 again, that all of this taken together is a mediation. You can see this here again, so like I said, kind of mediating, serial mediating hypotheses for both pathways. So what did we do? We did a cross-sectional online survey and investigated 465 chronic pain patients, mostly female, with quite high pain intensity, social constraints due to the pain and general strain, and also I think mean years of 12 years of pain. I also indicated the typical most common pain disorders that they had, which were fibromyalgia, chronic pain disorder, somatoform disorder, and complex regional pain syndrome, as well as endometriosis. And we also had a control group with healthy adult people, also predominantly female, and mean age was 30 years. Those are the measures we use. So we use the stress mindset measure to assess stress mindset, the social identity map approach for social identification. We used some subscales which are already previously defined from the brief COPE, and the well-being index to assess general well-being, and the patient health questionnaire to assess depression. And as you can see on the reliability rates, those are all quite good. So let's get to what we found. So this is basically the mediation approach you just saw earlier with our hypotheses, just with the results indicated. The model had adequate fit indices, and I'll just walk you through this now complex looking thing, which is actually very, I tried to make it a little easier by indicating in green which pathways were significant and in red which ones weren't, which are luckily not that many red ones. So you can see here that having a chronic pain condition was in fact associated with a rather negative stress mindset. So viewing stress as something negative, impeding your health, performance, well-being, etc. Whereas having a rather positive stress-enhancing mindset was associated with more positive coping behaviors, positive reframing and active coping. And those ones, on the other hand, were associated with a higher well-being and lower depression scores. And you can see that also having a chronic pain disorder or condition was associated with lower well-being scores and higher depression scores, so as a direct path. For social identification, we also did find that having a chronic pain condition did in fact lead to lower levels of social identification, whereas having higher levels of social identification was associated with more positive coping behaviors like instrumental support coping and emotional support coping. However, we did not find that those coping behaviors, instrumental and emotional support coping, had any influence on well-being. So neither on general well-being nor on depression. However, what we did find, what we did not previously assume, is that social identification also, like higher levels of social identification, had an impact on positive reframing and active coping behaviors, and might therefore impact well-being and depression through those coping behaviors. So a little different than we expected, but still, yeah, a nice effect for the affected patients. Regarding indirect effects, basically what you just saw from the different green lines, those indirect effects in the mediation were also significant. So in general, the path from group to stress mindset to positive reframing and active coping on general well-being and depression had significant indirect path coefficients. This was not the case for the assumed relationship with social identification, but however, those not expected but found pathway from social identification through positive reframing and active coping on depression and well-being, those indirect effect indices were also significant. So we can assume a mediation here. Thus, one could say that hypothesis 1, 2, 3, 4, 5, 6, 7, and 7 were significant, whereas hypothesis 8 and 9, so the effect from social support, instrumental and emotional support, coping on well-being and depression, and therefore also the mediation hypothesis, were not significant. Yeah, so what does that mean for chronic pain patients or chronic pain therapy? So we would suggest integrating a stress mindset training and social identification into therapeutic approaches to chronic pain, for example, in psychotherapeutic approaches. To our best knowledge, neither one of them is a specific part of psychotherapy for chronic pain disorders, but there are already existing training methods. So there is an existing stress mindset training by Crum et al., which is available, and there is also a method to foster social identification, which is called the Groups for Health approach by Haslam et al. And it might be an idea to integrate those two things into chronic pain therapy. We are actually researching that further at the moment. So we conducted an online training for chronic pain patients, integrating those two things, and are evaluating that. So yeah, we're kind of trying it, but I think this work is just a nice overview of those two variables that are not yet a part of chronic pain therapy, but as there are both susceptible factors like social identification and stress mindset training can be trained, and therefore we might just have to look a little bit deeper into those concepts, which might be helpful for chronic pain patients but aren't used yet in therapeutic approaches. So that was it from me. Thank you very much for your attention, and I am very much looking forward to your questions in the end.
Thank you so much, Isabel. Very, very interesting. And thank you for such a good overview and so many hypotheses. I like it. so many things to address. But thank you so much for sharing that. I'm sure there's going to be some brilliant questions and brilliant discussion afterwards, after we have a presentation from Elena. As a reminder to everybody watching, you are able to submit questions into the Q&A function, and of course, general comments into the chat as well. And you can do those anonymously if you wish. So feel free to get your questions in. Once we have our next presentation, we will have some discussions, and we have an opportunity, a fantastic opportunity for Isabel and Elena to be here to answer your questions directly instead of sending an email, which will likely get lost in everybody's boxes as they tend to be. So we have them here today. So please ask those questions. Fantastic stuff. Elena, let's hand it over to you. Thank you so much for joining us. We are super interested in your presentation. Feel free to take it away.
Okay, I'm going to share. Okay. Okay. I'm Elena Robles. I'm going to talk about a study of the effects of a mindfulness program in the attentional pattern of people with chronic pain. By way of introduction, all we know that chronic pain is one of the main causes of disability worldwide. And until now, the main treatment for chronic pain has been the use of painkillers, other medical intervention, or other type of medication. But in many cases, they are not effective to reduce the pain in chronic pain patients, and they also have a high addictive potential. So in the last year, from a psychological view, the interest for the attentional mechanism involved in chronic pain has increased, and also the effectiveness that non-pharmacological intervention could have to modify the attentional pattern of people with chronic pain, like therapies focused in the attentional control and breathing, which is the main interest of this study. Sorry. So in this study, we wanted to explore or to analyze the attentional pattern toward stimuli expressing pain in comparison to neutral ones in people with chronic back pain. And also we wanted to analyze the difficulty in disengage attention from both type of stimuli, and also the effectiveness of a mindfulness-based stress reduction program to modify the attentional pattern and also to improve other psychological symptoms. And regarding this, our hypotheses were that a pain-adapted mindfulness-based stress reduction program would be useful to reduce the attention to pain-related stimuli and also to increase the ability to divert the attention away from pain information in comparison to neutral information. And also, we expected that this program will be also effective to improve the symptomatology associated to pain. To do the study, we recruit participants with chronic back pain, specifically with a discopathy, for at least 2 years. And the inclusion criteria were being older than 18, obviously, having a diagnosis of discopathy, having normal or moderate mobility, no experience in mindfulness, and also having a normal cognitive performance, because they have to do an experimental task, so it was important, this criteria. And the exclusion criteria were having substance addiction, severe psychopathologies, and having a very limited functional capacity, because they had to do the program and there were some movements, so it was important to have an appropriate functional capacity. And I can show, okay. Well, the total sample size was 39, 22 participants in the experimental group and 17 in the control group. And both groups were similar in terms of age and sex. There weren't any significant difference. The course was a mindfulness-based stress reduction program, but was adapted for people with chronic back pain. The yoga exercise, the duration of every session was modified for people with back pain. And this course was given by very professional with a great experience, because there were physiotherapists, experts in mindfulness and also in chronic back pain. And the program consists of 9 sessions of 2.5 hours and a 4-hour intensive session, more or less at the end of the program. The total program was like 3 months, more or less. These are the psychological measures we took regarding depression, anxiety, stress, pain catastrophizing, and kinesophobia, which are very related to back pain or musculoskeletal pain. Also, pain acceptance, satisfaction with life, well-being, and some aspect of mindfulness. And regarding the attentional indexes, we choose some indices related to the early or late stage of attention, like time to first fixation duration, total fixation duration. And we also include an attentional disengagement index, which has not been very studied in this type of studies. The stimuli we use were the pain and neutral phases taken from the Montreal Pain and Affective Phase clips, which have been also validated by my team recently in the Spanish population. And this is an example of how we present every pair of phases to participants. Now, about the task, it was composed of 2 subtasks, which happen at the same time in every trial, not one first and the other after the first one. So the first subtask is a free viewing task, and the second one is a disengagement task. And now I'm going to show you an example of a trial. Every trial started with a cross fixation in the middle of the screen, and participants were asked to look at the cross for half second. After that, a pair of paint and neutral faces appear on the screen, and participants were asked to freely look at them for 5 seconds. And this is the free viewing task. Once this 5-second finish, they start the other subtask. And depending on the trial, when participants fixate their attention in one of the two faces, the opposite face is replaced by a geometric figure, which could be a pentagon or an hexagon. And this is the disengagement task. Maybe it was like 64 trial, maybe 5-6 minutes per task. So it wasn't longer. And the whole procedure of the experiment was this. All participants from both groups came to the lab to sign the informed consent and also to fill in the questionnaire I have mentioned before, and also to do the experimental task. When all participants were assessed, the experimental group started the program for 3 months, more or less. And when they finished the program, both groups came again to the lab to fill in the questionnaire and to do the experimental task again. To be honest, our idea was that now at this moment, the control group start the course again, so we could have more data about the effectiveness of the program. But it was at the end of February 2020, so COVID appeared and we were closed in our houses, so it was impossible to continue the study and we have to stop here. But it's a pity. And well, regarding the result, this table shows the mean and standard deviation for every index, for paint and neutral faces, and for the whole sample without dividing by groups. And as we can see, there are significant difference between attention to paint and neutral faces in the two indexes related to the early stage of attention. So by means that all participants or overall participants took less time to first fixate on paint faces in comparison to neutral faces. And they also did a longer first fixation for paint faces in comparison to neutral one. Based on these means, we calculate a bias score, and this bias score, when scores are higher than 0.5, means a preference to attend or to watch paint faces. So in base of this bias score, I show this table, this graphic of the effectiveness of the program in the attentional pattern. So very quickly, as we can see here, there was any significant effect of the program on the attentional pattern and neither in the disengagement index. So, but the program was effective to improve the psychological symptomatology associated with chronic back pain. The experimental group reduced the level of depression, magnification, and stress, and they also improved the level of well-being and satisfaction with life. So at least the program is effective to improve the symptomatology. Well, as conclusions, we found the presence of attentional bias in people with chronic back pain because they took less time to first fixate in pain phases, and also they did a longer fixation. But well, and this result confirmed the previous study, the previous finding of other studies which have found the existence of attentional bias to pain-related information in people with chronic pain. But also, it's important to mention that recent meta-analysis have found that these attentional bias are not exclusive of people with chronic back pain or with chronic pain, because they are also present in people without pain, healthy people. So maybe these bias are more general than we thought. And regarding the effectiveness of the program, it wasn't effective to modify the attentional pattern. These findings differ from previous studies, which have found an effect of meditation in a attentional pattern, but the difference between this study and the previous one is that the other study used healthy participants, not with chronic pain, and they were based on reaction time instead of eye tracking indexes, which are more reliable. Well, although the program was not effective to modify the attentional pattern, I think it's possible to see a tendency in the experimental group to reduce the perfixation duration to pain-related physics in comparison to the control group. This difference is not significant, but maybe with a larger sample size it has been possible to find a significant effect. So for me, at least, these results are promising and they motivate us to still study the effectiveness of the program in the attentional pattern. And well, the program was not effective to modify attentional pattern, but it was effective to improve the symptomatology related to pain, to chronic pain. And this is also in line with previous studies that have found that different types of mindfulness-based programs are effective to modify or to improve the symptomatology, not only associated to chronic back pain, but also in other different illnesses or also in the general population. And well, finally, I would like to finish by mentioning some limitation and strength of this study. As limitation, I think it's important to say that the sample size was not large enough. Initially, there were 50 participants, but there were 11 dropouts due to medical problems and eye tracking problems. Secondly, we couldn't control the medication, but almost every participant took medication and it was very difficult to control. And we use static stimuli instead of dynamic stimuli, which could be more representative of the pain emotion. And as strengths, I will mention that a participant having any previous experience in meditation, the teacher were very qualified to give the course, and also that we include a new attentional paradigm with an attentional disengagement index, which has not been very studied. And well, I have finished with this.
Fantastic, Elena. Thank you so much for that information. Very, very interesting and well done through the troubles of COVID as well, which has messed up quite a lot of our research. But yes, it's very, very interesting. Thank you so much for that. There are some questions coming in, which is brilliant stuff. So we have a great amount of time right now, maybe 25 minutes, 20 minutes to discuss the work. Thank you so much for sharing that. Just as a reminder, please pop your questions into the Q&A function that you can see. There are a couple in there, and I can see Isabel has started to provide a little bit more information for everybody as well. So it just shows this is a great chance to ask our fantastic speakers some questions. Very briefly, before we dive into some questions specific, I would love for an opportunity for each of you just to briefly give the audience an overview of your experiences, currently where you're working, and your role in sort of, if it's research, clinician, something like that. So Isabel, could you give us a very brief introduction to yourself?
Yeah, sure. Happy to. So I am actually a psychotherapist and I am doing my PhD at the Goethe University in Frankfurt. So my research is basically around chronic pain, but mostly focused on social identification and stress mindset, not only in chronic pain patients, but also in other like subclinical groups, which are just exposed to maybe feeling isolated from others due to a condition they're in, and also experiencing chronic stress or strain also due to just circumstances they live in. So for example, next to chronic pain patients, I also do some research of children of mentally ill parents, which are also exposed to chronic stressors and maybe sometimes feel socially isolated from others with like mentally healthy parents. So I try to link my work as a psychotherapist with my research interests, and in my psychotherapeutic practice. So I'm actually just starting my own practice in 2 months. So I also focus on like similar patient groups. So that is a very, very nice way to kind of try out new things in the practical field, but also get new ideas for new research topics from patients. Yeah.
I guess it's the perfect mix of everything that we would love to do, you know, and good luck with the opening of the practice in the future. But yes, I think being in touch, and we all kind of appreciate the value that brings, being in touch with the people that we're trying to help, and help that enforce or influence the research that's been doing, and it makes a beautiful little circle which works perfectly every time, I'm sure. But thank you so much for that. Elena, would you like to give a brief introduction to yourself? Tell us more about your experiences.
Yeah, sure. Well, I'm a psychologist. I have finished my PhD last month in the Complutense University of Madrid, where I'm working now. And well, my thesis, because it's my experience until now, my experience short, was about attentional bias in chronic pain or in other pain contexts, and also the use of non-pharmacological alternatives like this study, and another one we have trying to publish now about the use of acceptance and distraction to reduce or to modify the attentional pattern. And we found interesting thing. And now that is all. I focus on attention, pain, and other cognitive processes, but I I dedicate to experimental research. I'm not clinician.
Fantastic, and congratulations on finishing what was likely a long process of the PhD. Congratulations. I'm sure you're glad to see the other side of that. But thank you so much for sharing your experiences, guys. And there are some questions coming in which we are going to shoot straight to. So forgive my pronunciation. Manuela says, from a clinical perspective, how might lower social identification manifest in a patient's interaction with healthcare providers or their engagement with treatment plans? And what should healthcare professionals, what should they look out for? How can healthcare professionals actively support or facilitate the strengthening of social identification in their patients? Are there any specific strategies or interventions you could suggest? I think this is a great question. And what the practical side of this is, how can clinicians identify that this is a need of something that needs to be addressed? And what can they do to support patients through that aspect of their pain management? Perhaps Isabel.
Yeah, sure. I also thought this was a very great question, especially how it might even like lower identification or compliance with the treatment. So I think how we can pay attention to that is just know social identification as a concept, and maybe do like a formal anamnesis about, do they have social resources? Does the patient have friend groups? Are they in contact with family, etc.? So like a very good social biographical anamnesis, and also ask the patient, how do you feel about the friend groups? Or pay attention to like little sentences. For example, do they often just complain about other doctors they go to, or complain about their friend groups or social groups they're a part of? Because that might be a sign that they maybe don't identify with those groups, and that might be detrimental to their well-being. And I think that's something that can just be very easily overlooked, because it's just not the focus of the therapy mostly, but it does play an important role. So basically just pay attention to those little signs, ask a few questions about the social environment of the patient. And yeah, I think when it comes to them maybe not identifying with you, for example, or if that impacts the therapeutic relationship, that is something you can maybe try to directly address and say that, yeah, maybe there are differences because like you do not have a chronic pain condition. Maybe that's why you can't understand the full experience of it, but ask them how that might be important for them, what you can do so that they feel more understood by you. Maybe there are other things that you share similarities with, not on a personal level, but like just what is important for them to feel like they can open up to you and feel understood by you, even though there might be some differences in identification. So I think that might be an approach.
And I guess bring in some of the results from your research that you've very kindly shared with us today. was it emotional support that was less correlated, or there wasn't a significant mediation effect between emotional support and well-being? Thinking about how we can support patients with their emotional support and their the kind of social support networks, is there kind of a clash there, or am I taking that wrong? If there's no mediating effect, of course, we might need to explore this further. But what kind of impact does that have on identifying social support networks for individuals?
Yeah, so we also did find it very surprising that there was no effect found from emotional support and also instrumental support on well-being and depression. And like you said, maybe it just has to be evaluated further, because I think there are also some studies which show this, and also like psychotherapy, of course, relies on emotional support helping people with their well-being. So maybe it was also just a little bit part of how we operationalized it. So this brief cope questionnaire has a lot of questions on various different coping strategies, and I think on the different coping levels it's just a few questions. So maybe if you would have used another approach specifically for emotional support coping, or like assessed it differently, or like in a psychotherapeutic way or sense, then maybe results would have been different. Maybe this is just due to the approach we used, because we wanted to check like for different coping behaviors. So we wanted to have a big data set on different coping behaviors, and then we checked like which ones might play a role. Yeah, but I think this is just due to operationalization.
Yeah, and I guess it still emphasizes the importance of these support networks, and I guess it's the value that patients themselves perceive in their own support networks, and what role does that play in their recovery, and the importance as seen through their eyes, I guess.
Yeah, and of course, I mean, also if you have a high level of social identification, it's not just getting support from them, like somebody helping you with moving or saying, oh, I feel with you, that's a very sad thing that happened to you, but also just having somebody to talk to, not feeling so alone. Like I said, also the same brain region might get activated when you feel lonely, like when you feel pain, so that might also exacerbate pain experience. And so just having a group, being able to talk to somebody might just help well-being through different pathways that we didn't build up in our hypotheses. Or also like if somebody talks back to you and gives you like a good tip or something, that also might lead to a positive reframing, for example. So maybe there are just different pathways of how that helps for well-being and health.
I guess it just emphasizes the complexity of what we're exploring here, and the ability for us to design research to address exactly that. It's a complex picture, which I guess is another good thing to reiterate. And thank you so much for that. Perhaps we can move through some more of the questions. Elena, I think this one's addressed to you. Thank you so much for sharing. It says, in the population without pain, where you found a bias regarding painful stimuli, did you look at negative effects? Did you explore that?
Well, when you study, for example, a pain intensity in people without pain, there's some studies have found a correlation between pain intensity and the presence of attentional bias to pain-related information, for example. And the same is in people with acute pain, with healthy people, or chronic pain. So that's the reason why maybe we should focus on a study what is the relationship between attentional bias and other cognitive or emotional processes, because I think that there is here is where the answer is we need. And also there are other psychological variables such as pain catastrophizing or fear of pain, which are very related to attentional bias in the general population, not only in chronic pain patients. So I think there is a relationship between attentional bias and other processes also in people without pain.
And other processes. And I guess the future research is to explore that further and look at the influence between those individually, and the effect that could have to really focus or make us focus on those specific components and how it can influence attentional bias. Very interesting stuff. You mentioned very briefly that that's kind of where your work is taking you. Is that where you're looking to move into? What kind of, perhaps we can come to that a little bit later about where you're going to be moving with the research, because there is another question here. It says, in Eleanor's study, it could have been interesting to explore medication change using questionnaires such as the MQSSII. Just want to make sure I get the correct amount of I's there, which is a medication quantification scale. Did you think about perhaps exploring that? Is that something that you would like to explore in the future? You know, medication change and its influence?
You said medication or meditation? Sorry, because I can't hear.
It's medication.
Medication. Okay. Yes, I would like to do that, but what we saw when we were doing this study was that there were 50 chronic pain patients, and some of them took one type of medication, another type, more doses. Other suddenly have a medical intervention, not by using medicaments, but other type of medical intervention. So it was very difficult because all of them were trying to participate in whatever thing can happen then. I also found an old woman, like 75 years more or less. She was so desperate with the intervention that she started to smoke marijuana, and she was not very keen on that because she was very desperate. So I think that it's very difficult to control the other things they are doing to relieve their pain, because they are trying to do a lot of things at the same time. And sometimes that medicament or intervention are advised by medic doctors, but other time they try to look for another option, another answer for their pain. So I think it's very difficult to control what they are doing to reduce their pain. But I think it's something very important to do, obviously, in order to control that variable.
And I guess controlling it would be difficult, as you mentioned there, but also it is a big part of people's pain management systems and their approaches is mixing a bit of everything to find out what works for them. So I guess you're right in mentioning that in controlling that, to really understand the relationship between those could be quite difficult, but nonetheless still very it could be important and something interesting to
Yes,
kind of
of course.
explore in the future. Fantastic. I want to kind of bring back to Isabel when we're thinking about stress. And you mentioned that you're going to be moving or working clinically, of course, which is super important for many healthcare professionals that are in the webinar today. I had a little bit of a question when you were talking about, how often is it that people actually hold the understanding that stress is an enhancing component, or they have a stress enhancing mindset? Because and maybe I'd be interested to hear what the influence on social context, perhaps sex, gender, religion, all these types of things that can talk about what stress means to them. How often is it that people actually think stress is a good thing for me? I can't imagine it's a lot.
Yeah, you're right about that. So it's quite rare. I feel like a lot of people, I don't really know if I experience in the clinical field any differences in like sex, gender, or age. I feel like in general, people mostly view stress as something rather negative, which is basically influenced by the media a lot, I think, and also by how the generations before us handled stress. And in the population in general, stress is often referred to as something rather negative. So I feel like the only people who come into the practice and hold a rather stress enhancing mindset are maybe a little more educated people, maybe especially in like the medical or biological field, who just know about sympathetic nervous pathways or something like that, and therefore because of that educational background can get to that opinion. But if you do not have that background, then of course, because of media influences, etc., people rather hold a stress as debilitating mindset. But I find it very interesting that if you talk to them about it and just educate them a little bit about it, which is also part in different psychotherapeutic approaches. For example, if you think about anxiety disorders, where you also educate people about sympathetic and parasympathetic nervous pathways, etc., and which role they play in coping in anxiety, that people are often very interested in that, and that it's not that hard to shift that mindset. It's just about knowing about how stress is adaptive in its nature in itself.
And I think that's kind of hopefully what this webinar is going to do is
I hope so.
specifically for clinicians is to provide, an emphasis of the importance of pain, but also of stress in pain, but also exploring strategies for clinicians to be able to reframe and positively shape the perception of stress and really help to understand the role that stress plays in pain. I can imagine, do you have any kind of, I want to say maybe like secrets, if you like, little resources that you could use or that clinicians could use with patients? Because I can imagine it's quite a difficult conversation to have, is to really talk about stress and why it could be positive in someone's pain experience that they've had for 30, 40 years. What are the little kind of secrets that clinicians can use, maybe turns of phrase or online resources that they could use in clinic from today?
Yeah, so you mean that patients won't feel invalidated or feel like, yeah, you're just imagining your pain or you're to blame or something like that? That I feel like that is a very important question. And yes, patients might indeed feel invalidated if you communicate them that maybe their pain is due to stress, and which is understandable. I would also feel invalidated if somebody told me that like this exactly. So yeah, I think it is important to pay attention to adequate patient communication and also use the biopsychosocial model for psychoeducational purposes. So this way you can avoid the trap of mind versus body dualism and educate them about the interactiveness and also complexity of biopsychosocial components and processes. And yeah, so with using this and also educating them about stress in general, so maybe just detach stress a little bit from the chronic pain context and just look at stress as the physiological concept, which is adaptive in its nature, and then differentiate between acute and chronic stress a little bit. So combining that biopsychosocial model and a stress in general education, not just stress in a chronic pain sense, might help for reducing feelings of invalidation and also stigma about stress. Because if you just avoid it because of the fear of invalidation, you might just increase the stigma of stress and can't use the beneficial effects of integrating stress mindset shift. And I think you can just, like you already said, language is key. So it's about how you phrase things instead of saying something like, your pain is just stress or just due to stress. You could say something like, your pain is real, but we know that stress can amplify the way the nervous system processes pain, and addressing stress could help to calm the nervous system and reduce your discomfort so that the patient feels validated and also sees like, we both want to reduce my discomfort, and this might be an unexplored way to do that.
And I can imagine that's exact response. It's the stress is playing a significant role in your pain. Might be quite difficult to begin a conversation about how stress might be mediating that. So thank you. Very, very interesting. Hopefully very, very easy for people to use in practice kind of from today. We do have one from Shira. Isabel, can you share with us the main principles of the of psychotherapy that focuses on social identification?
Yeah, sure. So this is basically an approach which is called Groups for Health by Haslam et al. 2016. And it is a treatment manual which was originally designed for depression, but has also been validated in different kinds of groups. So basically people who withdraw from social interactions or want to have more social contacts. And what you do is you basically, first of all, you do a very well anamnesis. So you can use the social identity map approach, which is you take a map and you list all the groups that you already have, and you also differentiate how important those groups are for you, how much contact you have with them, how identified you feel with them, how positive you feel regarding you belonging to that group, and also how compatible those groups are with each other. Because incompatible groups can also pose a different problem with social identifications. If I'm part of different groups which are very, very different, so I might also have a threat to my self-definition. So you just look at what you have and also what you lack, and then you can look at, okay, so with which group would I like to identify more, maybe, or is there a part of my self-definition, so something that is very important for my personal identification, like a hobby, etc., or a political opinion, whatever, that is not really represented in my social identity map. And then you just start to brainstorm with them, okay, how could I maybe become a part of a social group that represents that part, which is important for me, for my personal definition, or are there some different social groups that I had in my earlier life, which, yeah, like life is, sometimes you lose contacts with groups, with certain people, but maybe I really like those people. Maybe I can reach out to them again. Which ones would they be? How could I do that? How could I get in contact with this new group? So it's basically just looking at what you have, what you want to, what is important for your personal identification, your self-definition, and then looking at how I integrate that into my social life.
Fantastic. Thank you so much. A very comprehensive response as always. Fantastic. So we have a couple more minutes kind of remaining. Thank you so much for your questions, everybody. I'd like to give the floor to Elena first. Thank you so much for sharing. And you mentioned before about, larger sample sizes needed, and of course this influence on symptomatology. Is that kind of where your research is going? I'd like to know a little bit more about what you're going to be exploring in this area sort of in the coming months and years. Tell us a little bit more about where you're going with this.
Well, yes, we wanted to have a larger sample size for the study. Now we have not planned any study with a mindfulness program. We have been doing more experimental studies with like coping strategies or how acute pain can modify the attentional pattern and that, but not with mindfulness program. And it's also very difficult to find the perfect sample because in this case, for example, people were older. Obviously, chronic pain patients are older than younger, but some of them have other problems. Sometimes it was difficult for them to go to the study, and having a larger sample size for this type of study with all people with chronic pain, which is very difficult for them. And we live in Madrid, so it's a very big city to go to the program, come back to house, to your home. So it's difficult. Now we are more focused on experimental studies with maybe healthy people, students, so we can get a larger sample size.
Okay, that makes perfect sense. Let's think of what we can handle and the best ways to answer the questions. But thank you. It's really, really interesting. And Isabel, what's for the future? What do you have sort of planned in the coming months, perhaps?
I want to do a study. We are planning a study to compare attentional bias to emotional phases compared to words, because now the experimental study are more based on images, facial expression and that, but not in words. So now the idea is to know if maybe it's better to use words instead of faces, if we can choose words to have a better result. Because, for example, the faces I have used in this study, after this study, we tried to validate in Spanish population, and we found that from 8 pain faces, 3 of them got a very low score from participants. So in the next study we are trying to publish now, we only use the 5 faces which got a high score, trying to eliminate those stimuli that maybe are not very useful to assess attentional bias. So now in the next month, I focus on that.
Fantastic. And that's kind of to increase the specificity. And you mentioned about dynamic visuals as well. So kind of emotional through not still images, through dynamic visuals, which is interesting. Thank you. Perhaps Isabel, where are we moving with your research? What can we expect from you in sort of the next months or years to come?
Yeah, so most certainly the evaluation of the training program, which I mentioned earlier. So we did do an online program for chronic pain patients where we integrate social identification modules from this Groups for Health approach, which I just presented a little, and where we also integrate a little bit of stress mindset education and reframing on stress. And yeah, so we just got the data now, and we will be evaluating this and hopefully have some nice results that even an online training might be a little helpful, because of especially those those challenges that Elena just mentioned. Like, they are often not that not that mobile, so they can't really go everywhere or have bad access to treatment options, especially in like more rural areas. So this is why we wanted to do an online training, which is probably not gonna fix everything, but is like a first approach for those variables, and I hope that we can have some nice results there.
Fantastic. And we're tailing the resources. That's exactly what we're trying to do. So thank you so much. I think this is a good time to bring it to a close. We have run slightly over, so apologies, but this is what happens when you have such interesting discussions. Thank you so much to Elena and Isabel for your time today. Really, really appreciate it, and some very, very interesting work. As mentioned before, the webinar is recorded, so you can access this via the EFIC Academy platform, and of course, YouTube and social media as well. Don't forget to share this online through social media platforms so we can get this discussion to everybody who might have missed the live version today. So thank you again for the questions. We do have a couple which we haven't managed to address, so apologies for that. But thank you so much for the interaction and of course the questions and the comments. I hope you both and everybody watching have a fantastic day, and I hope to see you all on the next webinar. Thank you so much for joining us today. Take care.
Thank you.